இப்போ நான் வீடியோ போட்டு பார்க்குறேன்.
I am monitoring.
ஏன் வராது?
Okay, Ramesh. Okay, fine. Madam, I think we can start. I think.
Yeah. The chairpersons are there. Anyway, I'll just introduce them.
Yeah. Chairpersons are there.
Okay. Good evening. It's indeed a pleasure to be with you all again for this webinar. And today it's going to be a very excellent webinar, I'm sure, because we are going to discuss about a very amazing organ, pancreas, which has always excited me. Because when we started, we didn't have much to talk about the pancreas. We just had 4 pages to read and one on congenital abnormalities of the pancreas. But now there are books on pancreas, and we have none other than our Dr. Amit, who will be talking, and Dr. K.R. Palanisabi will be introducing. But before that, I would like to introduce all our chairpersons, Professor K.R. Palanisabi, from the senior most here, who's done so much of work in pancreas, and Dr. Chandrasekhar. I remember he's been always interested in the pancreas. I remember him doing EUS and thing for a lady who was pregnant and had problems in the pancreas, and interesting endotherapy he used to do. Dr. Mohan Prasad from Coimbatore, his meetings on pancreas we've all attended, and we have a surgeon also, Dr. C.G. Balachandran. So we have eminent chairpersons, all very senior most and experienced and having expertise in the field of pancreas. So without wasting much time, I would just hand over this session, and I'm sure it will be beneficial to everyone who's attending. And I think this would be recorded and we can re-listen to it. And we wish you all a wonderful and a pleasant evening. Sorry, we are not able to give you bouquets, but this is our wishes to all of you. Thank you.
Good evening and welcome everybody. I'm very happy to introduce a good friend of mine, Dr. Amit Maydeo, and we've been associated with him for a long time. In fact, he was the faculty for the first endoscopy workshop in a government setup in 1990. And after that, and Amit Maydeo has been associated with us for several other meetings. And Dr. Amit Maydeo is a surgeon, basically, turned endoscopist. And he is a pioneer in the field of therapeutic endoscopy in our country. And his work in ERCP is, he has done a lot of path-breaking work in ERCP, developed new protocols in the treatment of pancreatic and CVD stones. And he has done pioneering work in third space endoscopy. He conducted numerous live workshops and training programs with which all the many doctors from our country were benefited, not only from our country, even overseas. And he has been an invited faculty in various international forums. And currently, Dr. Amit Maydeo is the founder, director of the Baldota. And he was the former president of the Society for Gastroenterology and Endoscopy of India. And he was the recipient of as the civilian award, that is for the Padma Shri from President of India. Without wasting much time, I would request Dr. Amit Maydeo to talk on endotherapy of chronic pancreatitis. Any other comments from other chairpersons on the topic?
No, sir.
After that. Yeah.
Should I begin?
Yeah, you can.
Okay, so first of all, I want to say that it is a great honor for me to talk to the Tamil Nadu chapter of Indian Society of Gastroenterology. And thanks to Dr. Malti and Professor K.R. Palanisabi, Dr. TSG, and all the chairpersons who are there today. The topic which was given to me was endotherapy of chronic pancreatitis. Is it better than surgery? But before I begin my talk, I just want to tell you that many years back, when I started my career, and I was trained by some famous surgeons from Mumbai, and when I was taking training from them, one of them had told me a long time back that when the question is wrong, the answer cannot be right. So here, if you see, is chronic pancreatitis endotherapy better than surgery? According to me, in today's scenario, the question itself is wrong. So the answer cannot be right. However, I'm going to take you through this series of slides. and unravel the mystery of chronic pancreatitis and related role of the endoscopist in chronic pancreatitis, and what are the changing concepts in this area over the last so many years. It's very important to remember that chronic pancreatitis is not a very simple disease. And if you study patients of chronic pancreatitis, not only in our country, but in this region of the world and in various parts of the world, you will realize that chronic pancreatitis is of varied etiology. It has a varied morphology and varied methods of presentation. And if you see here, the type of patients which come to the doctor uh, from the Western region, Western world or the Eastern world vary considerably. And the spectrum also varies depending upon whether the etiology is alcoholic or whether it is idiopathic. Here you can see a series of ERCP pictures of patients of chronic pancreatitis. And in almost everyone, you see here a completely different pathomorphology. Well, so therefore the treatment is not going to be simple. If you were to see the manifestation of a patient of chronic pancreatitis, they can manifest in different pathophysiologies. Either it can be a stone predominant disease, or it can be a stricture predominant disease, as you see predominantly in the West, stone predominant disease, as you see predominantly in the East, or mainly in our peri-equatorial regions. You can have a combination of stones along with strictures. You can have associated biliary strictures. You can have associated pseudocysts. And in some patients, you can have a hard gland, and they can also have a pseudomass or inflammatory mass type of appearance. Now, these type of pathomorphologies also vary in this entire spectrum, from idiopathic or what we call tropical chronic pancreatitis to alcoholic chronic pancreatitis. Well, all said and done, even today, in spite of so much of advances in endotherapy, in surgery, in laparoscopic surgery, in everything, still the indications for intervention in chronic pancreatitis still continue to be pain relief. Otherwise, it is normally considered that we should not intervene in a patient who does not have pain. Unfortunately, the modality, the cause, or the etiology of pain is still not very clear. However, it is attributed to either neuropathy, increased intraductal pressure or parenchymal pressure, pancreatic ischemia, and sometimes even acute inflammation. Just want to state that there are two evolving indications which have evolved over the past decade or so because of the advances in the endoscopic treatment of chronic pancreatitis and even good results of surgery. That is a possible improvement in the exocrine and endocrine function. So therefore, even if patients of chronic pancreatitis present to you without pain, but who have a gross exocrine endocrine function, and if they have a pathomorphology which is suitable, probably these patients are suitable candidates for intervention or therapy, because from our latest data, from our experience, from the world experience, we have noticed that around 30 to 40% of patients will show an improvement in their endocrine function, and almost 60% patients will show improvement in exocrine function if you do intervention and you relieve the ductal obstruction. Endoscopically treatable manifestations, if you ask me, are three. Number one is stone disease. Number two is strictures, which are dominant strictures, not strictures which are throughout the duct. And third, which are pseudocysts. And I will come to that, but these pseudocysts are a little bit different from what you see in acute pancreatitis. So three endoscopically treatable manifestations of chronic pancreatitis: stones, strictures, and pseudocysts. And of course, as I mentioned to you before, other indications would be the treatment for weight loss because of exocrine deficiency, and diabetes, which is because of an endocrine problem. So how do we go about it? If you see stone disease, there has been sufficient amount of literature, sufficient amount of data, which has now shown us that what actually is the cause of stones in chronic pancreatitis. Number one, it can be either a genetic or an alcohol etiology. But what is most important is in all patients who form pancreatic stones, we have found that they have increased protein content in the pancreatic juice. And if you study the pancreatic juice in patients who form stones in chronic pancreatitis, the amount of protein in their pancreatic juice is 400 times that of a normal person. So therefore, what happens is in many of these patients, because of the high protein load, the pancreatic juice becomes rather thick, and therefore there is a sluggish flow of the juice. These proteins, they form plugs and they block the duct, because of which these patients develop episodes of clinical or subclinical episodes of acute pancreatitis. And on these protein plugs, there is deposition of calcium. So the calcium goes and deposits on the protein matrix, and depending upon the amount of calcium that deposits, you either have radiopaque stones or you may get radiolucent stones. So this is the way, basically, the pathogenesis of stone formation in chronic pancreatitis. What about stricture formation? It is now well known. There has been a hypothesis which was floated by a German pathologist almost 50 years back called Kloppel. It is called as the Kloppel's hypothesis, and he called it is the necrosis fibrosis sequence. It is was Kloppel's hypothesis, where he postulated, and this holds true even today, that, as I mentioned before, because of some reason or the other, there is clinical or subclinical acute pancreatitis, which causes an injury to the pancreatic duct. That leads to a stricture formation, sluggish flow, further episodes of acute pancreatitis, further injury, and slowly, because of this vicious cycle, the gland hardens, and that stricture can become tighter and tighter because of further fibrosis. So this is the pathogenesis of pancreatic strictures. What about pancreatic pseudocysts, which happen in chronic pancreatitis? Number one, the reason is recurrent acute pancreatitis episodes. There is ductal rupture, leakage of juice, and collection. Fortunately, in collections which occur in chronic pancreatitis, these are usually small, and invariably collections in chronic pancreatitis are communicating with the pancreatic duct. So therefore, they are much more amenable for endotherapy than a collection which occurs due to acute pancreatitis. When a patient of chronic pancreatitis comes to you for treatment, today we have come to a conclusion, and I would like to say that it is mandatory that we do these investigations before you embark on any treatment or decide whether the patient is suitable for endotherapy or surgery. Most important is a simple X-ray or a fluoroscopy. Many of us forget to do this. So if you have a C-arm in your department, at least take the patient on the table, do a fluoroscopy. And with this, you will be immediately able to pick up whether the patient has radiopaque stones or no. Even if the patient comes to you with a sonography or a CT scan report of stones, fluoroscopy becomes important. Because if stones are shown on a CT or on a sonography, and on fluoroscopy you don't see them, that means these stones do not contain so much calcium. They are radiolucent stones. So therefore, these stones can be taken out quite easily if the duct morphology suits endotherapy approach. Second important test to be done, any patient of chronic pancreatitis is an MRCP. MRCP today is the gold standard, because with this you can study the ductal anatomy. You will come to know whether there is associated stricture, whether there are pseudocysts, whether there is a complex disease, whether there is a SOL. And if you do find that there could be a complex disease or an SOL, you have to follow it up by doing an endoscopic ultrasonography or even a CT scan. EUS can also be associated with the EUS guided FNAC if there is a mass-like appearance which is seen in the ductal morphology. Well, once you have done a fluoroscopy, and you can either the stones can be radiopaque or radiolucent. You can see here 20 to 60% of patients of chronic pancreatitis form stones. So therefore, stone disease is the predominant pathomorphology in chronic pancreatitis. These stones can be radiopaque or they can be radiolucent, and you can pick them up immediately as soon as you do a fluoroscopy. The different or the characteristics of stones occurring in the pancreas is funny, because you see here, they are not as simple as bile duct stones. And single or multiple radiopaque stones are seen in 90% of the patients who come to us in India. Only 10 or 15% of patients have radiolucent stones. They cannot be seen on fluoroscopy. And the characteristics of pancreatic stones is, as against bile duct stones, is they are not only hard, but they are spiculated, almost like the coronavirus. They are impacted in the pancreatic ductal epithelium. They are usually associated with pancreatic ductal strictures or complex pathologies. And sometimes these stones are inaccessible. Only in around 10 to 15%, you have stones which are radiolucent. So in case you do have a patient who has radiolucent stones with a dilated duct, as we quite commonly see in our country, endotherapy is extremely effective. And as you can see here, when we do an ERCP and we opacify the pancreatic duct, you can actually see that the duct is full of big, big stones. In fact, one will feel that how are we going to take out these stones by simple endotherapy, whether this patient is going to need surgery. However, endoscopic techniques have now evolved very well, and we are applying the techniques which we use for bile duct stone removal. For example, we go ahead and first perform a pancreatic sphincterotomy. You see here, pancreatic sphincterotomy is usually performed at 12 o'clock to 2 o'clock direction. It is not done at 11 o'clock direction as we normally do a biliary sphincterotomy. Then, in patients who have got a dilated duct with radiolucent stones, which are not seen on fluoroscopy, we can easily do a balloon dilation of the pancreatic sphincter. As against a bile duct balloon sphincteroplasty, in pancreas, we do a CRE dilation only up to 12 mm. We usually do not exceed 12 mm CRE dilatation. And after we have dilated the pancreatic sphincter, by using a simple balloon extractor, even if the entire duct is full of big stones, which are radiolucent, you can achieve a complete ductal clearance, sometimes even in a single sitting of ERCP. In case you feel that the ductal clearance is not adequate, then what we do is we temporarily place a pancreatic ductal stent, either a 5 French or a 7 French stent, call the patient back after 3 months, repeat the ERCP, complete the ductal clearance totally, and then leave the patient on a total stent-free trial. So this way we can achieve a complete ductal clearance with endotherapy in those patients who have a suitable pancreatic ductal anatomy and radiolucent stones. As I mentioned to you, radiopaque stones are a little different. They're not as easy to remove as radiolucent stones. However, you may be lucky. You may get a patient who has a radiolucent stone, but the duct is dilated. There is just a single stone like this floating inside the duct. Now, these patients can be treated very well by use of a simple basket. You may not even need to do a balloon sphincteroplasty as you saw on the previous video. So once again, we go ahead and do a pancreatic sphincterotomy towards the 2 o'clock position. Use a simple Dormia basket. Either it can be a simple Dormia basket, or we can use a wire-guided Dormia basket. Put the basket till the tail of the pancreas, open the basket, and almost like fishing, you just pull the open basket down and you can take out radiopaque stones provided they are small. But this is not the case in most of the times. In many cases, patients whom we get in India, we get pictures like this, where the duct is dilated and they may have stones spread out in the duct. They may have only located in the head or in the mid body, sometimes in the tail. And in these patients, it is mandatory before you perform an ERCP that we have to pulverize these stones into powder. And this is done by the technique of shockwave lithotripsy or ESWL. With the latest generation shockwave lithotripters which we have, it not only has an increased accuracy, increased efficacy, but increased safety. If you use simple lithotripter, which is used in kidney for kidney stones, sometimes the shock waves can get dissipated and you may not be breaking the stones sufficiently and the stones may not pulverize. In fact, you can cause damage to the surrounding organs, including kidney, and the patients may have lot of duodenal contusion, intestinal contusions, and they may also present with hematuria. So what we do in these patients is, if you have a suitable anatomy, even if the stones are radiopaque, don't do an ERCP, don't place a stent, don't place a nasopancreatic catheter, subject the patients to ESWL. How do we perform ESWL? We usually use a special type of a machine which has got a very narrow focal point of only 5 millimeters. Patient is kept in a supine or a semi-supine position. The stones are localized by fluoroscopy in 2 axes. It's important that you have a ESWL machine which has got an integrated C-arm. You should not have a machine where you attach the C-arm from outside, because if you attach the C-arm from outside and it is not integrated, the localization is not proper and your shock waves will diffuse. While doing ESWL, patient is likely to have pain. So either you can have a propofol or a intravenous, total intravenous analgesia or anesthesia. Sometimes we can also use epidural anesthesia. Of course, these patients have to be monitored by pulse oximetry, NIBP. The bellow containing the water of the machine comes in close contact with the anterior abdominal wall all by the side. And then we start delivering the shock waves with low amplitude first, level 3. And we keep on delivering waves. 5 to 10,000 shocks are given per session. And you can give 2 or 3 sessions like that on alternate days. So usually we maintain an alternate day schedule. Patient does not need to be admitted. Patient can be sent home. Patient is called back. And the end point of ESWL is very important. The end point of ESWL is pulverization, not fragmentation. So we have to fragment or pulverize the stones till they become less than 3 millimeter fragments. So you see here, how do you know that your ESWL is proper? You see here, these are the stones before, and here you see this is in German language called as a Steinstrasse appearance. That means a road which is full of stones. So the stones spread all along the duct. You can see here the fragments, the multiple pulverization, the powder is there of the stones. Only when you achieve this, then you can go ahead and perform a ERCP and do a ERCP for extraction. So how do you know that the ESWL is effective? Loss of density, spreading along the duct, and sometimes if there is a single stone, the stone can even disappear. So you may have a single stone in the duct, and endotherapy or ESWL can even serve as a monotherapy in these patients. After you have performed ESWL, then we go ahead and do a ERCP. This is done in the same way. We opacify the duct. These are all pulverized stones now. So we go ahead and now we are doing a cutting of the sphincter. You can see that the whitish pancreatic juice is coming out along with some of the stones. And then we once again use a balloon. And once we sweep the balloon, you can see the pulverized stones which are coming out. Many times when we do ERCP in these patients, some stones do remain inside. In fact, some stones are stuck on the wall of the duct. So therefore, it is better, instead of just keep on attempting the balloon extraction, either we can place a 5 French stent, 7 French stent, call the patient back after a couple of months, repeat the ERCP, and before doing ERCP, once again do a fluoroscopy. If you find some more radiopaque stones, do a repeat ESWL, then take them for ERCP, and then complete the therapy, and by which we can totally clear the duct of all its stones. All this is provided that the ductal morphology is suitable. If the patient has multiple strictures along with stones, it is not as simple as I showed you in the video. Therefore, we have to dilate the strictures first. We have to place multiple stents. We have to pulverize the stones, keep on dilating the stricture, and then attempt endotherapy. Sometimes we find that the stones are so much impacted that our wire does not go through. So then in such a situation, we use a US guided rendezvous approach. You see here, under endosono guidance, we can locate the pancreatic duct through the stomach, posterior wall of the stomach. We puncture it with a 19 gauge needle. Then we opacify the pancreatic duct through the body or through the tail. And once the needle is inside properly in the duct, we can place a wire through the 19 gauge needle and get it across the ampulla of Vater, and then pass the ERCP scope, catch the wire, pull the wire up through the channel, and then over that we can pass our instruments and complete the therapy. So in patients where you are failing cannulation through the main papilla or the minor papilla because of an impacted stone, impacted powder, you can attempt an US guided rendezvous approach, and by this you can achieve a cannulation. In fact, nowadays with the advent of cholangioscopy, we have started using the same Spyglass cholangioscope for the pancreas, and we have started doing pancreatic endotherapy in some patients who don't respond to ESWL. For example, you see here radiopaque stones in the pancreatic head. They have not responded to ESWL, and the stones are not getting pulverized, but we need to remove them. So we perform a pancreatic sphincterotomy, do a little dilation with a balloon, and then after doing a balloon dilation of the pancreatic sphincter, we pass the spyglass inside the pancreatic duct. You see here, and even if the stones are located in the head, we can directly see the stone, and usually these stones can be pulverized quite well by using the laser, holmium laser. However, once again for this, our spyglass has to reach the stone. If the stone is located behind a stricture, this procedure is likely to fail. So stricture and stone combination is a bad combination, and if you find that, then you usually have to resort to stenting protocol, make the stricture dilated, allow your instruments to go in properly, and then perform a ESWL, pulverize the stones, and then start taking out the stones. So therefore, a combination of modalities is required. What about those patients who present with stricture predominant disease? I just want to tell you, it's not as simple, because various types of strictures you can find, and this you can pick up on MRCP itself. You can have a single stricture, multiple strictures, tight strictures, soft strictures, complex strictures. And this can be the pathomorphology in chronic pancreatitis. And that is exactly the reason why in those patients who have an alcohol etiology, usually they have stricture predominant disease, they have complex ductal disease, and therefore the results of endotherapy are usually dismal. However, in spite of all that, if you have a stricture which is just a single or maybe two strictures, then the common protocol which is now practiced all over the world is what was published in 2014 in the ESG guidelines, is as soon as possible you should try to place a stent of at least 10 French. If you can't place a 10 French stent in the beginning, at least place a 7 French or a 5 French, call the patient back soon, try to upgrade it to a 7 French, then place a 10 French, and then leave the 10 French stent inside for at least 6 months to 1 year. After 1 year, when you take out the stent, if the stricture has opened up, if it has resolved, you can leave the patient alone if the patient does not have stones. But if the stricture is persistent, then the patient should be given a chance to decide whether the patient wants to go for a surgical consult. If not, then we can persist for endotherapy, and endotherapy will now consist of placing multiple stents to treat that stricture. So what we do is, in these patients, we place multiple stents of 10 French and place 2 or 3 10 French stents, leave those stents inside for another 1 year. In spite of that, if the stricture does not resolve, we should not persist with endoscopic treatment. I know that nowadays expandable metallic stents have come, and for single dominant tight strictures in the pancreas, even if you can't dilate them, sometimes we use a corkscrew device or Sohendra stent retriever device. We can also use what we call as a cystotome for cutting the stricture. We can use a cystotome over wire, cut the stricture, be able to place a stent, upgrade the stent after 3 months, 2 10 French stents, or maybe slowly 2 7 French, then 1 10 and 1 7, and then 2 10, leave it for 1 year. After 1 year, if it does not respond, these patients should be sent for surgery instead of trying to persist with endotherapy and then later on sending the patient too late for surgical. Here you see here, we are used, for example, if you have a very tight stricture, we can use the Sohendra corkscrew device, which is called as a stent retriever. This was a patient who had a pancreas divisum. Here you see here that we are now cannulating the minor papilla. We go inside, do a sphincterotomy of the minor papilla. Because the dilator did not go through, we pass a 10 French Sohendra stent retriever. We pass inside, and by rotating the screw type of device, we can dilate even a very tight pancreatic ductal stricture. However, I feel that better than this device is a cystotome, because it causes lesser damage to the pancreatic ductal epithelium. And instead of using a Sohendra stent retriever, we can use the cystotome. This is a fully covered expandable stent. The bumpy stent was invented. It was launched by a few companies many years back. We have used it on a few occasions. In some patients, the results are quite good. The problem is, because of the design of this stent, even if the stricture resolves, at the end of the stent, because of the flanges which impinge inside the pancreatic duct, new strictures are likely to form because of the stent itself. Of course, the initial trials with expandable metallic stents have shown good results, but in whichever patients we have used them, we have found that expandable metallic stents can cause sometimes trouble because they can migrate, they can spontaneously go out and cause trouble. Pseudocyst in chronic pancreatitis, less than 9% spontaneously resolve as against acute pancreatitis. But the good part is almost 60% have ductal communication. So therefore, in pseudocysts which form in chronic pancreatitis, transpapillary stenting is the first line of treatment, recommended, grade A. You see here, because these pseudocysts are in communication with the pancreatic duct, if you drain the main duct, these pseudocysts usually will drain out, and they will slowly resolve over a period of time. So the message which I want to convey is, chronic pancreatitis is not so simple. I again mentioned to you that it has varied etiology, varied morphology, and varied manifestations, varying from tropical pancreatitis to idiopathic pancreatitis. And most of the literature which has been published on the pathogenesis of chronic pancreatitis in the world today, if you study it very carefully, you'll realize that alcoholic pancreatitis and idiopathic or tropical pancreatitis are actually two ends of the same spectrum. Because if you were to see, alcoholic pancreatitis is not due to alcohol alone. There are so many alcoholic patients who never develop chronic pancreatitis. Whereas tropical pancreatitis is not due to genes alone. Because if you study genetic mutation in patients of tropical pancreatitis, you will find mutation in only around 40 to 60%. What about the remaining 40% or 50% who do not have genetic mutation? So therefore, what is the cause of chronic pancreatitis in these patients? So you see here, the new insights in pathogenesis of chronic pancreatitis is TIGAR-O hypothesis is these patients of chronic pancreatitis have a defective protective factors. So what happens is, because of defective protective factors, even any sentinel episode of acute pancreatitis, which can be because of alcohol, biliary, viral, environmental toxins, drugs, divisum, metabolic, obstructive, they keep on developing clinical and subclinical episodes of acute pancreatitis, necrosis of acinar tissue, activation of pancreatic stellate cells, fibrosis, and then a full-blown chronic pancreatitis. So what is most important is defective protective factors. And you see here, 4 genes are attributed, or they have been as culprits which can lead to this defective protective factors. First is the SPINK1. Everyone knows only about SPINK1 gene. SPINK1 gene you see here is responsible for maintaining the integrity and regeneration of acinar cells. CFTR gene you see here regulates the pancreatic duct secretion, and it has the ability to flush the activated trypsin. Whereas CTSB or cathepsin B gene regulates the intracellular pH and the calcium levels. Whereas the REG1 gene, REG1A gene, it prevents pancreatic lithiasis by inhibiting crystal nucleation in the juice. So therefore, if there is a mutation in any of these 4 genes, the protective mechanism in these patients is lost. So therefore, these patients become more prone. So changing insight today is what? In peri-equatorial countries like India, you have the same in Sri Lanka, the same in Bangladesh, the same in some African countries. They have what we call as subclinical pancreaticopathy. That means the pancreatic juice in all these patients is low in enzymes, high in calcium and protein, and high in lactoferrin. And the gland is vulnerable to injury. So therefore, second or multiple hits can lead to chronic pancreatitis, whether it be because of diet, environmental toxins, alcohol, smoking, etc., etc. In addition to the 4 genes which I showed you before, 10 new protective genes are still now being studied. And therefore, there is basically, I have a feeling that all chronic pancreatitis, I think, is genetic in its etiology. In addition to that, all these factors play a role. This is exactly the situation. Now, why are the results of endotherapy not uniform all over the world, all over the country? The main reason is people have not understood which patient to treat, how to treat, and there is a wide variation in etiology and pathomorphology. Most of the controlled clinical studies which have come in the world, randomized control studies, have been published in the West, where they see predominantly alcoholic etiology patients. Pathomorphology is completely different. You cannot compare endotherapy with surgery in those patients. Unclear selection criteria. The criteria for selection for endotherapy have to be proper. Then availability and experience with ESWL. You must have realized from my talk that if you do not have ESWL, a good machine available with you, treating radiopaque stones is not worthwhile by endotherapy, because the first step of endotherapy is ESWL. Then arbitrary stenting regime. Many of the endoscopists still do not know which stent to place, how long to place, what type of diameter, what should be the characteristic, whether there should be flaps, how many holes, whether it should be pigtail or non-pigtail, whether it should be 5 French, 7 French, 10 French, and how long to keep it. And so therefore, undefined endpoints of therapy. See, when you embark on endotherapy of chronic pancreatitis, in your mind, you should have defined endpoints. For example, ESWL, you should know whether ESWL has worked, whether you have pulverized the stone, whether you have done stenting. There has to be some endpoint. You can't keep on putting stents permanently. So if you have these criteria proper, then you can select these patients properly. So therefore, coming back, the spectrum from west to the east, alcoholic, idiopathic, and tropical. If you ask me personally, in today's scenario, if you have this type of a pathomorphology, these patients should directly go for surgery. Alcoholic etiology, stricture predominant disease, and complex morphology. As an endoscopist, we should not even try to attempt endotherapy. Or if patients who have small duct disease, you keep on placing stents, your stents are doing much more harm than benefit. the patient keep on coming back to you with pain, and you keep on changing the stents. All that the patient does is spend money. But if you have patients who have a dilated duct, even if they have stones spread all over the duct, whether it is radiopaque or radiolucent, depends upon whether you have an ESWL facility, I think these patients are eminently suitable for endoscopic therapy. So that's the end of my talk. Thanks for your attention.
Thank you, Dr. Amit, for the excellent talk. I think there are a lot of questions, burning questions will be there. And I would like to ask you, the patient in a case of chronic pancreatitis has had a lateral pancreatic genostomy. In spite of surgery, sometimes they continue to have the pain. Therefore, the duct is dilated, no stones. What will be the approach in such a case?
Well, in such a case, you should offer them endotherapy, because then what we can do is we can go from the ampulla of Vater, we do a pancreatic sphincterotomy, if required, dilate the balloon with a balloon, the pancreatic sphincter, and then we place a stent throughout the dilated pancreatic duct coming from the duodenum and going into the jejunum, where they have done a pancreatic jejunostomy. And the stent has multiple holes. So now we are draining the pancreatic duct completely. We get these patients quite often. In fact, some of these patients have developed some stones also. If they have developed stones, then we shoot the stones, pulverize them, and then perform endotherapy.
Thank you. Any other questions, any comments from the other chairpersons?
Can I just intervene as a surgeon?
Yes.
Dr. Panisam, your question was that the patient of pancreatic jejunostomy comes with a pain.
Yes.
We should remember that as many of these patients who undergo pancreatic jejunostomy, the stoma of pancreatic duct and the jejunum is like a chicken-hearted stoma, what we say.
Okay.
What we usually, a surgeon recommends is you should be a longitudinal pancreatic jejunostomy. As much as possible, you do it. But most of the patients whom I have done a revision pancreatic jejunostomy, I found that they have done a very limited 1 or 2 centimeters, especially by laparoscopic surgeons. Actually, if you just see, you have the principle of doing a pancreatic jejunostomy is you have to completely cut the entire pancreatic right from the head up to the tail.
Okay.
So most of these patients who undergo the pancreatic jejunostomy surgery, they do not undergo properly actually. That is one of the reasons they come with when it is undrained ducts, they come with a pain.
Can I ask a question, sir? Professor KRP, sir?
Yes.
Okay. Just enjoyed Amit's lecture as usual. He's out of the way, out of the world. Congratulations for a wonderful lecture. And you're a great demonstrator as well as a speaker. I have a question to Dr. Balachandra sir and also to Amit. So what is the smallest duct size that you will accept for a lateral pancreatic jejunostomy? Is it 7 millimeters or 1 centimeter? You need a 1 centimeter? See, when people are doing microscopic surgeries in other fields, why are not the pancreatic surgeons, why can't they just anastomose with a microscopic surgery, even smaller ducts?
Actually, the pancreatic duct, they are divided into small duct disease and large duct disease. What is the definition of a small duct? A small duct is one. The smallest diameter is 4 millimeters, 4 to 5. And there is an excellent paper written by Dr. H. Ramesh, where he has performed a good amount of lateral pancreatic jejunostomy in a small duct disease. And he found the relative this pain, patients were pain-free. So a small duct disease, surgery is recommended, provided you are experienced in doing how to do it.
Can I have comments from Amit on that small duct disease? Because the US does not believe in surgery in the small duct disease. Like they don't operate lateral pancreatic jejunostomy. So what is your comment on this?
I'll tell you one thing, that from last 30 years experience of small duct disease and large duct disease and everything, that probably we may not have that quality surgeons in Mumbai or in Maharashtra, but I have found that patients of small duct disease don't do well either with endotherapy, neither with surgery. And we have found that they continue to have pain. And endotherapy, definitely no. Because whenever we have attempted endotherapy in these patients of small duct disease, we have found terrible results. because all that the patient does is keeps on coming back with pain. And you don't know whether the stent is causing the pain or the disease is causing the pain or what's happening. And you finally take out the stent and you just tell the patient that you can't do anything. And sometimes you have referred these patients to surgeons. Some surgeons operate, some don't operate. As told by Dr. Bala, I think it depends upon the surgeon's experience of operating on small duct disease.
I think there are many questions in the chat box. Dr. Rubal or Dr. Palnisamy can take it. Can I read the question?
Yeah, you can go ahead with the questions.
I think it should be a rapid fire. There's a question from Chennai Karthik. What are the chances of disintegration of the stent within the pancreatic duct on long-term placement, Dr. Amit?
That entirely depends upon the type of stent you are using and depends upon the material of the stent. See, because stents, as I told you, are made from various designs, various materials. And nowadays, a lot of companies are manufacturing stents. There are some Indian companies who are also making stents of inferior grade material. And these stents can easily disintegrate. And you can have fragments of stents left inside the pancreatic duct.
Okay.
And therefore, it becomes impossible to take out. So choose your stent properly, choose it from a reliable company. The material has to be very good and it has to be tested. Otherwise, there's no point in placing that stent in the pancreas.
I think Kannan surgeon, he feels that I have seen pancreatic duct grossly infected when they come for surgery after endotherapy. I think he's angry with someone. How do you manage pancreatic duct grossly infected when they come for surgery? What could be the reasons you would like to know?
The question is to me or to Dr. Bala? Is it to me?
The surgeon is asking, I think.
It's to the endoscopist. So once again, this is a completely technical related issue.
Yes.
Number one, if you have injected contrast in the pancreatic duct, you have to make sure that the contrast has drained off properly. Otherwise, that's a source of infection. Number two, make sure that your stent length is proper, stent diameter is proper, the number of holes, the placement of holes is proper, so that the stent does not cause more complications rather than benefit. So the stent should cause benefit, not lead to complications.
Yes.
So these are all technical issues. And that's why pancreatic endotherapy is not simple. See, I'll tell you something. Even when we are doing endotherapy, the guide wire which we use, sometimes the assistant is too enthusiastic. And if he manipulates the guide wire too enthusiastically, you can perforate and you can make punctures in the secondary branches. That makes the pancreatic juice to leak out. There will be a collection that will get infected. So every maneuver, everything has to be done extremely gently, even if you're treating chronic pancreatitis. And if you do that, use the proper instruments, proper accessories, you can avoid these complications.
I think there's another question. Dhruvin Shah has asked, any relation between success of endotherapy and duration of chronic pancreatitis, Dr. Amit?
No, I don't think there is any relation. It entirely depends upon, the success depends upon pathomorphology. And if you have done your homework properly, a proper MRCP, if required EUS and CT, and you have ruled out complex ductal disease, and if it is endotherapy suitable, the success will be high. But if you just choose any arbitrary patient, then the success will not be high. ITS.
A removal of asymptomatic pancreatic stones, do you feel they will definitely prevent diabetes mellitus later on in life? Because I think Mayo Clinic are a little different in this thought.
Because Mayo Clinic is seeing alcoholic etiology.
Okay. So,
and we are seeing a different pathology, pathomorphology. And we have found at least a 40% improvement in exocrine and endocrine function.
I think that's very good. And I think it's a very good teaching point. Kanagavel from Chennai has asked, is there any role of endoscopic sequential balloon stricturoplasty in the PD? Sequential balloon stricturoplasty.
No role, because pancreatic strictures are extremely tight and fibrotic. Only balloon stricturoplasty is not sufficient. It requires a continuous dilatation. So continuous dilatation can be achieved only with a stent, in increasing the diameter of stents or number of stents.
I think role of pancreatic enzyme replacement in large duct disease, I think may not be a part of this discussion, but questions come all the way from Delhi. So probably Sanchit Singh would like you to just comment on that, sir.
We usually give pancreatic enzyme replacement.
And many of them have said it's an excellent presentation. And there is one more indication for intervention in asymptomatic biliary stricture. I don't know why he wanted that. Maybe it is part of chronic pancreatitis, a biliary stricture. If you feel, do you think we have to put a stent in that?
It depends upon the meaning of asymptomatic. The patient may not be clinically symptomatic, but the liver function test could be deranged. And if the LFT is deranged, if the duct is dilated, if there is a stricture, it needs treatment.
When will you refer patient directly to surgery without endotherapy? I think you've answered the question in your last slide, but I think maybe they missed it or something. Rajesh from Salem has asked that question.
Small duct disease, complex ductal strictures, inflammatory head mass, associated biliary stricture are all directly going for surgery. They are not suitable candidates for endotherapy.
Dr. Malti?
There's another question from Karthik.
Yes, you can ask, yeah.
This is despite the high migration state in the pediatric stems, is there a role for the stems in PD, pancreatic duct? The high migration of pancreatic duct, the pancreatic stem, is there any role for stems?
If you ask me personally, there are some studies which have shown good results with SEMS, fully covered expandable stents. However, it is not up to the level that it can be recommended routinely in clinical practice. So I do not think that SEMS should be as a routine first level clinical practice to be placed for pancreatic ductal strictures. You should place plastic stent.
Dr. Amit?
Yes, yes.
An excellent talk as usual. We have listened to his master's voice on chronic pancreatitis. The subject is very close to your heart. I have a couple of comments to make it.
Yeah.
In my opinion, the best indication in chronic pancreatitis, where very rewarding, is pancreatic ductal leak and fistula and pancreas ascites, where surgeon would be very pleased to hand over such cases. So I want to reiterate here is, if I get a patient of pancreatic ductal leak and pancreas ascites, that would be it's a delight for a endotherapy person. The second thing is I've come across, as you said, a pancreatic ductal stricture after bumpy stent placement. I really could not figure out why he developed a stricture beyond the stent point.
Because of the flange.
And I had to give up that the procedure. I have not been doing now bumpy stent in pancreatic ductal stricture. The questions to you is, when do you recommend minor papilla cannulation? And I'll finish up 3 questions so that you can take up. You said there can be some improvement in endocrine exocrine function. How reliable it is? Because still the opinion is divided. Even because many patients ask us after the endotherapy whether my diabetic will improve or I can reduce the pancreatic enzyme, which is a very difficult answer, I said. The third one is the title itself, as complex as the subject, the topic itself is. The title is endotherapy, because TGB is watching me, Kannan is also watching me. Surgery is better than endotherapy or endotherapy. I think you made it very clear, but if you choose appropriately, it's a complementary to each other. But I want to draw the attention of the surgeon here. If I keep trying all cases endotherapy, that's a failure. If you keep trying surgery for all cases, that is a failure. And NEJM, that controversial paper, in my opinion, came very small number of group of patients they have taken. And whoever reports, if the endoscopy reports, that's a bias there. If the surgeon reports, there is a bias is there. And when the surgeon report, they take the very complex endotherapy cases where they have failed it and they compare it. And when the endoscopy report, they take a very complex surgical cases, they report. But one thing is very clear, for long-term results of pain relief, surgery is better than endotherapy. With this, I just want to have your opinion, Amit. Exocrine function, endocrine function, minor papilla, and long-term results.
Okay, minor papilla is the first question I'll tell you. When do you approach through minor papilla? Number one is we approach through minor papilla if you can't approach through major papilla and if there is a persistent duct of Santorini. So that means what we call as incomplete pancreas divisum. That means there is some duct which is connected to the minor papilla, but from major you can't enter. Then you approach through minor. Sometimes there are stones also in the duct leading to the minor papilla and stones in the duct of the major papilla. So then you have to approach both the papillas, major as well as minor. And third, of course, if patients who have complete divisum, Patient of complete divisum, you have to approach through the minor papilla. So these are the three criteria. Now regarding endocrine, exocrine function, I'll tell you what I tell the patients. I never tell them that this is 100% relief or improvement of exocrine endocrine function. Because we have found from our experience and from surgical data, it has been shown that there is improvement of endocrine exocrine function from the research papers of Neelan, who did lateral pancreaticojejunostomy. And we found exactly the same results in our data, that when we did a proper ductal clearance, there was an improvement in exocrine in almost 60%, endocrine in almost 25 to 30%. So what I normally tell the patients is, it is unreliable. We do not know whether your pancreas will respond, but there is a 20 to 40% chance that there is some improvement. And patients usually accept. Patients say, oh, if there is 20% chance, I want to take that chance. I want to go ahead. And your third question was, what was it, TSC?
Long-term versus short-term results, where the surgeon will embark on long-term results are better with the surgical.
See, I think, as you rightly said and put it, alcoholic etiology, 80% of patients are more suitable for surgery than endotherapy. In tropical pancreatitis, 60% patients are more suitable for endotherapy than surgery.
That means we are dealing more with the tropical.
Yeah, and we are dealing more tropical. So I think we should attempt, and we should at least select patients properly. See, as endoscopists, we should not be dogmatic. I very clearly showed you how to assess the patient beforehand. And if you have a proper pathomorphological mapping, beforehand you can say whether you are going to succeed or no. Unnecessary, there's no point in trying and putting stents.
Amit, I have one final question to you.
Yeah.
What do you enjoy in life? Is it doing pancreatic endotherapy or doing yoga, meditation, pranayam as you were doing for 60 days? Please tell us.
60 days before I used to enjoy pancreatic endotherapy, but today I enjoy yoga, meditation and pranayam.
Wow.
I think there are just four more questions in the chat box, Dr. Amit. One is risk of pancreatitis after endotherapy, how to prevent? From Surat, Dr. Smith has asked.
Well, in chronic pancreatitis, usually these patients don't develop acute pancreatitis after endotherapy because the pancreatic gland takes your intervention quite easily. However, in spite of that, we give these patients a diclofenac just before starting the ERCP. And after the procedure, we usually keep these patients on a liquid diet for a week. Okay. If you have done major endotherapy and major manipulation.
Kanagavel from Chennai again has asked, sir, how far are we from endoscopic pancreatico-enterostomy for chronic pancreatitis? How far are we from that?
Oh, we are almost doing that now. We are doing EUS-guided pancreatico-gastrostomy. So if we have a tight pancreatic stricture, and if you can't go from the main papilla, what we are doing is EUS-guided. We are puncturing the pancreatic ductal, dilated duct, and we are putting a stent and then converting it to a metal stent. We can place a metal stent joining the pancreas to the stomach. So we are performing a pancreatico-gastrostomy. I am not very sure whether this is the right physiological approach from the surgical standpoint. However, we have found the patients become asymptomatic after doing this procedure.
Tirumal from Coimbatore, role of pancreatic sphincterotomy in idiopathic recurrent pancreatitis.
Means what? I mean, idiopathic recurrent pancreatitis, but depends upon the morphology. If the duct is dilated and if the duct is containing some stones or maybe sludge or even pancreatic stone protein, you can perform a sphincterotomy, clear the duct, leave a 5 French stent only temporarily, and then take out the stent as fast as possible. Because one thing you have to remember in pancreas, don't leave unnecessary foreign bodies in the pancreas for long time. So unnecessary stenting should be avoided. If at all you place stents, they should be temporary.
Amit, I think he's meaning recurrent acute pancreatitis, probably because of the biliary microlithiasis, doing an ERCP and a sphincterotomy.
No.
Biliary sphincterotomy.
Biliary sphincterotomy. But just pancreatic sphincterotomy is of no benefit in these patients.
Kannan, from a surgeon from Chennai, I know he wants head mask, how to manage. He's handing that also over to the endoscopist.
What?
Head mask.
Head mask.
Phlegmon.
In head mask.
Phlegmon. But no word, we don't use that. Head mask is written.
Phlegmon.
Dr. Kannan, you can speak, you can unmute and talk.
No. I think what Kannan is asking is the mass in the head, which is an inflammatory mass. versus a malignant mass, how to probably manage or differentiate.
I'll tell you what.
Phlegmon. 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 Phlegmon.
So I do not know whether there is any terminology like that now in chronic
That's now
pancreatitis.
gone, yeah.
Yeah, but inflammatory mass in the head, we will assess with endoscopic sonography. However, I will tell you that EUS is not a very specific test to know or differentiate malignancy in inflammatory head mass in the setting of chronic pancreatitis. The success rate of achieving a diagnosis is very low. But if you are highly suspicious of a mass, the patient should be sent to a surgeon. And I'm quite sure the surgeons will be happy to do a head coring procedure or something like that in such a case.
Yeah, in fact, I wanted to just talk about this. In our country, more than 80% of the patients of chronic pancreatitis come with a head mass. And in such patients, we not only completely do a removal of the, that is, we do a coring of the head. That's called phrase procedure, wherein we do a nice head coring, go up to the uncinate process, empty all the stones, open up the entire pancreatic duct, do a pancreatitis. Another controversial question about Dr. T. Chandrasekhar regarding diabetes. We know chronic pancreatitis, 1/3 of the patients, they already have diabetes. The remaining patients, when you operate or do endotherapy, whether there is an improvement of this diabetes, there is a lot of controversy. But what is stated in the literature is, the patient after such procedures will not deteriorate. His diabetic status will not deteriorate further. Suppose if you do not operate or do endotherapy, he may go for endocrine, exocrine insufficiency. But you intervene and do the endotherapy or surgery and decompress the duct, there will not be deterioration of the further of the diabetic status.
That point is agreed, Dr. GB. Whether the surgeon or endoscopist will take the credit only, I am asking. One thing very important is who does the procedure, who does the endotherapy, who does the surgery. I'll tell you one example where if the patient has undergone surgery, comes back 6 months later with a pain. Then we found out they have done the pancreaticojejunostomy in the body and the tail region. Head they safely could not do for some reason or other. So we had to do the revision surgery. Head coring had to be done. Same is true with the endotherapy also. As Amit nicely pointed out, there should not be even one foreign body, in the meaning that a stone or stricture, the stent should not be there. So what is most important is the completion of the procedure. The experience and expertise matters. Otherwise, endotherapy may fail and surgeon will take the credit. The surgery may fail and endotherapist will blame.
Whatever
so I think
we do,
most important training.
Whatever we do, TSC, as endoscopist, I want to give a message that you should have clearly defined endpoints. And if you do not have clearly defined endpoints and proper selection of patient, whatever you do is going to fail. Because
So
chronic pancreatitis,
where we need to end, where the surgeon should start, or where the surgeon should end and endoscopy should start.
Yeah. For example, I'll tell you what, if you have a stone disease, your endpoint has to be stone clearance, not just placing stents. If you have a stricture, your endpoint has to be stricture resolution. And if you can't achieve that in 3 years, better send the patient to a surgeon.
The most difficult thing is head mass in the pancreas, in a chronic pancreatitis. If I have a clue like duodenal infiltration or CA99 is grossly elevated and pointing more towards malignancy, and a quick observation for 1 or 2 months or the FNASG might help us. That is a very, if you have in doubt, better to hand it over to surgeon. And whether it is a malignancy, we are happy that you have done the surgery. If it is a benign also, you have taken the lead, you have done that for the head coring.
So we work very closely with our surgeons in Mumbai. And therefore, our surgeons have faith in us, we have faith in them. So it is like a very nice team. And unnecessarily, they will not do a pancreaticojejunostomy if the patient is suitable for endotherapy.
Chennai is also as good as Mumbai, Amit.
But Amit, you don't need any surgical opinion. You yourself is a surgeon. Today I enjoyed your talk because it was absolutely unbiased, your talk.
Thank you.
You are very, I was really enjoying your talk as a surgeon. You are really called as a surgical endoscopist.
But I hope the endoscopist also enjoyed my talk.
So you are a surgeon plus an endoscopist. So your absolute designation is changed completely. And today you have brought out excellent points and you were very impartial. And so it has come up from a horse's mouth, I would say. Thank you.
Thank you, Dr. Amit. Excellent talk.
Thank you.
Dr. Panisamy, you can give your final word.
Thank you once again, Dr. Amit. It was an excellent talk. As always, all your talks have been excellent. This is really super. Thank you very much.
Thank you so much.
Thank you so much.
Bye.
Thank you.
It's a
Bye.
great honor and privilege. Thank you. Bye.
Thank you, sir.
Paul?
Yes, sir. Sir, you please